Ever wondered why some couples struggle to conceive? Today we dive into the world of infertility, specifically focusing on female factors. Infertility is a term that may be familiar to many, but not everyone fully understands its implications. It denotes the inability to conceive or carry a pregnancy to term after 1 year of regular, unprotected intercourse. It's a condition that affects between 10 to 15% of couples worldwide, warranting an investigation into both members of the couple. Infertility is not a one-size-fits-all term. It's divided into two main categories: primary and secondary infertility. Primary infertility refers to cases where conception has never occurred. This is in contrast to secondary infertility, which is diagnosed when a couple has conceived in the past, but is currently unable to do so. It's important to note that the majority of couples, around 75%, achieve pregnancy within 6 months of trying. This number increases to 85% within a year and 90% within 2 years. So, infertility is not an immediate conclusion if a couple doesn't conceive right away, but rather a diagnosis made after a reasonable period of trying without success. Understanding infertility requires a grasp of the basic requirements for conception. 5 main factors come into play: the ovary, the tube, the cervix, the endometrium, and of course, sperm. Each of these has a vital role in the process of conception. The ovary releases the egg, the tube transports it, the sperm fertilizes the egg, and the fertilized egg implants itself in the endometrium, or the lining of the uterus. But what happens when one or more of these factors don't function as they should? That's where we encounter the many causes of infertility, which we'll delve into in the next segment. Now, having understood what infertility is, let's delve into the causes. What causes infertility in women? Let's explore some factors. Infertility, in simple terms, is the inability to conceive or carry a pregnancy to term after 1 year of regular, unprotected intercourse. It can be primary, meaning there have been no prior pregnancies, or secondary, occurring in the context of a previous conception. So, what are the factors that contribute to female infertility? How do they disrupt the crucial requirements for conception, which include an ovary, tube, cervix, endometrium, and of course, sperm? First, let's discuss ovulatory dysfunction, which accounts for 15 to 20% of infertility cases. This can be due to issues in the hypothalamus, pituitary, or ovaries. For example, hypothalamic amenorrhea, prolactinoma, hypopituitarism, and conditions like Polycystic Ovary Syndrome, premature ovarian failure, and luteal phase defect can all disrupt ovulation. Systemic diseases like thyroid disorders, Cushing's syndrome, renal or hepatic failure, and even stress, poor nutrition, and excessive exercise can also contribute to ovulatory dysfunction. Next, we have outflow tract abnormalities, which are present in another 15 to 20% of infertility cases. These can be due to tubal factors, such as pelvic inflammatory disease, adhesions from previous surgery, peritonitis, endometriosis, or ligation or occlusion due to a previous ectopic pregnancy. Uterine factors, which are less common, can include congenital anomalies, intrauterine adhesions, infections, fibroids or polyps, and endometrial ablation. Cervical factors, such as hostile or acidic cervical mucus, anti-sperm antibodies, and structural defects, can also play a role. Endometriosis, a condition where tissue similar to the lining of the uterus grows outside the uterus, is another significant contributor, accounting for 15 to 30% of infertility cases. Then there are the cases where multiple factors are at play, which is the case for about 30% of couples dealing with infertility. And finally, there are those cases where the cause remains unknown, which is true for about 10 to 15% of cases. Understanding the causes of infertility is the first step. The next step is knowing when to investigate. This is typically after 1 year of regular unprotected intercourse for women under 35, after 6 months for women between 35 and 40, and immediately for women over 40. Investigations should also begin earlier if there's a history of pelvic inflammatory disease, infertility in a previous relationship, prior pelvic surgery, chemotherapy or radiation in either partner, recurrent pregnancy loss, or moderate to severe endometriosis. In the next scene, we'll delve deeper into these investigations and the potential treatments available for female infertility. When should a couple begin investigating infertility issues? Let's find out. Infertility can be a complex issue with many factors at play, and it's important to begin investigations at the right time. The general rule of thumb for couples under 35 years of age is to start investigations after 1 year of regular, unprotected intercourse without conception. This is based on the understanding that about 75% of couples will achieve pregnancy within 6 months and 85% within 1 year. However, as we age, the time frame for starting investigations changes. For couples aged between 35 and 40 years, the recommended period is after 6 months of trying without success. The reason for this shortened time frame is that fertility tends to decline with age, hence the need for earlier intervention. For couples over 40 years, it's advisable to start investigations immediately. At this age, the chances of conceiving naturally are significantly lower, and early investigation can help identify any potential issues and initiate appropriate interventions. That said, there are exceptions to these general guidelines. Investigations should begin earlier if there's a history of pelvic inflammatory disease, infertility in previous relationships, prior pelvic surgery, or exposure to chemotherapy or radiation in either partner. Likewise, if there's a history of recurrent pregnancy loss or moderate to severe endometriosis, investigations should not be delayed. These guidelines are not set in stone and should be adjusted based on individual circumstances. Every couple is unique, and what works for one may not work for another. It's always best to consult with a healthcare professional who can provide personalized advice based on your specific situation and medical history. In the next scene, we will delve into the specifics of infertility investigations. We will look at the different tests and procedures used to diagnose the causes of infertility and the treatment options available. Now that we know when to start investigating, let's look at how we investigate. Investigating infertility involves several steps. Here's what they entail. When it comes to diagnosing infertility, a variety of tests and procedures are used to pinpoint the root cause. Let's delve into the specifics. To diagnose ovulatory issues, certain tests are carried out. On day 3 of a woman's cycle, follicle-stimulating hormone, FSH, luteinizing hormone, LH, thyroid-stimulating hormone, TSH, and prolactin levels are measured. If a woman shows signs of hirsutism or excessive hair growth, dehydroepiandrosterone, DHEA, and free testosterone levels are also checked. Around day 21 to 23, a serum progesterone test confirms ovulation. Additionally, a woman might be asked to monitor her basal body temperature to detect a biphasic pattern, which is indicative of ovulation. Tubal factors contributing to infertility are investigated using a hysterosalpingogram, HSG, or sonohysterogram, SHG. These procedures can be therapeutic as they may open up the fallopian tubes. A laparoscopy with dye insufflation, also known as a tubal dye test, can provide further insights into the state of the fallopian tubes. Peritoneal or uterine factors are another aspect of the investigation. These factors are typically evaluated via HSG or SHG, as well as hysteroscopy, which gives a direct view of the uterine cavity. In some cases, other factors come into play. For instance, a karyotype, which is a test to examine chromosomes in a sample of cells, might be carried out to identify genetic abnormalities that could be contributing to infertility. It's important to remember that these tests are not standalone determinants. They are part of a wider investigation that takes into account several aspects of a woman's reproductive health. These investigations also take into consideration the age and overall health of the woman. For instance, investigations should start after 1 year of regular unprotected intercourse for women under 35. For women aged 35 to 40, investigations should begin after 6 months. For women over 40, investigations should commence immediately. Moreover, there are certain conditions that necessitate earlier investigations. These include a history of pelvic inflammatory disease, infertility in a previous relationship, prior pelvic surgery, exposure to chemotherapy or radiation in either partner, recurrent pregnancy loss, and moderate to severe endometriosis. These investigations are essential in charting the course of treatment. They provide valuable insights into the potential causes of infertility and help medical professionals tailor treatments to the individual's specific needs. Armed with the results of these investigations, the next step is treatment. Scene script. Treatment for infertility varies based on the underlying cause. Let's explore some common treatments. One of the first steps in treating infertility is education. This includes understanding the timing of intercourse in relation to ovulation. For a couple trying to conceive, it's recommended to have intercourse from 2 days prior to 2 days following presumed ovulation, and ideally, every other day. Now let's move on to medical treatments. These are often used to treat ovulatory dysfunction, which accounts for 15 to 20% of infertility cases. One common medication is clomiphene citrate, also known as Clomid. This drug is an estrogen antagonist that stimulates the ovaries to produce more eggs. However, it's important to note that Clomid is not suitable for everyone, and its use should be carefully monitored by a healthcare provider. Other medical treatments may be used to address systemic diseases, such as thyroid conditions or Cushing's syndrome, that can impact fertility. If a woman has a condition like Polycystic Ovary Syndrome or Premature Ovarian Failure, specific treatments for these conditions may also improve fertility. In cases where there are outflow tract abnormalities, such as tubal factors, medical treatments might not be enough. In these cases, surgical interventions may be necessary. For instance, if a woman has had a previous ectopic pregnancy that resulted in tubal ligation or occlusion, a surgical procedure might be needed to restore fertility. Similarly, uterine factors like congenital anomalies, intrauterine adhesions, or fibroids may also require surgical intervention. Procedures can range from minor surgeries to remove polyps or fibroids to more extensive procedures to correct structural abnormalities. In some instances, assisted reproductive technologies, such as in vitro fertilization or intrauterine insemination, may be recommended. These treatments can be particularly useful when infertility is due to factors like endometriosis or hostile cervical mucus. However, it's important to remember that not all infertility cases can be explained, and in 10 to 15% of cases, the cause remains unknown. In these situations, treatments might involve a combination of the strategies we've discussed, and it often requires a process of trial and error to find the most effective approach. Infertility can be a challenging journey, but with the right knowledge and medical support, many couples can find a way forward. Infertility is a complex issue with various causes and treatments. We've journeyed through a comprehensive examination of female infertility, shedding light on this important topic. Let's briefly revisit the key points. Infertility is defined as the inability to conceive or carry a pregnancy to term after 1 year of regular, unprotected intercourse. It affects 10 to 15% of couples, and it's crucial to investigate both members. The causes can be primary, with no prior pregnancies, or secondary, following a prior conception. The requirements for conception are multifaceted, involving the ovary, tube, cervix, endometrium, and sperm. Disruptions to any of these elements can lead to infertility. Female factors can be categorized into ovulatory dysfunction, outflow tract abnormalities, and endometriosis, with multiple or unknown factors also playing a role. When it comes to investigations, the timing is key. For women under 35, investigations should begin after a year of regular, unprotected intercourse. For those between 35 and 40, after 6 months, and for women over 40, investigations should start immediately. The investigation process is thorough, encompassing ovulatory, tubal, peritoneal, and uterine factors. It's a comprehensive approach to ensure no stone is left unturned in identifying the cause of infertility. The treatment of female infertility is multifaceted, centering around education, medical intervention, and a focus on timing intercourse in relation to ovulation. Medical treatments include ovulation induction, with further options explored depending on the identified cause. Remember, knowledge is power. Understanding infertility is the first step towards overcoming it. This exploration of female infertility has been a journey of understanding, shedding light on a complex and often misunderstood issue. Thanks for tuning in to MedSign Health 360. Don't forget to subscribe, share your thoughts in the comments section, and give a thumbs up to encourage us to bring you more interesting, challenging, and high-quality videos. Your engagement helps us continue our mission of making crucial medical and health knowledge accessible to everyone. Together, we can foster better health and a better life.